Good morning. Welcome to the Games. Hoping to update you as to what the health and care system that's already now in place, that came in place in April of this year, looks like and how it may impact upon healthcare for you, your friends and your family. So if we can go to this big exploded diagram. So this center on here, if we could, and can you, that's it, keep on coming. Out a bit, off a bit. Do you remember the golden shot? That's it, keep coming. I just hold her there, just go off a bit. Yeah. Okay, viewer, well what we've got, and the bits that really impact on us very much, is the clinical commissioning groups are taking over from the primary care trust, the folks who caused us quite a lot of problems some time ago, when they, if you remember, did introduce a new model of care based on changing for the better. Some of you have got reasons to think of that, not with the greatest degree of love. I don't know whether it's practical to come straight in on top of this particular, and whether the camera's good enough. Carry on coming, carry on coming, carry on coming, carry on coming. Well, you're getting there, aren't you? Hold it. You see that, can you? So you've got the NHS Commissioning Board and the clinical commissioning groups. The clinical commissioning groups are made up of our own GPs. It's a board of 7 GPs plus other lay members, and they now have the responsibility not only of delivering their own service, but purchasing around 60% of the services that the NHS purchase. So the budget we have, and if we could come back out a bit and head off to where the money is, because it's where the money is that's really key to what we get or what we don't get. And the money is down here. As you can see, we're looking at about nearly £1 billion is available for the area that was covered by NHS Suffolk. That was everywhere excluding Lowestoft area. Now that will be split into two, because there is a West Suffolk group of commissioning group, and there is also an East Suffolk, which is a mix of the Ipswich doctors and, if you like, the Suffolk Coastal and other doctors. So we are back to where we were many years ago, when it was the East Suffolk Health Service. Now, the amount of money that comes into us here in Suffolk is determined by a thing called the funding formula, and it's quite a complex process, as you would expect. Anything designed by bureaucrats invariably is, and it's got about 28, 29 elements within it, and people living in Suffolk get about the lowest, one of the lowest per head funding of anywhere in the east of England, and that's based on the basis that you live longer than anybody else, pretty much. They don't seem to take on board that an awful lot of you that are living longer actually moved here from somewhere else. What we'd like to really see is how good or otherwise is the actual health of the, I don't know whether the right word to use is indigenous, but people that are born here, raise their children here and die here. Just how much is the whole of life expectancy skewed by folk who come in with lots of resources, buy up second homes, move in, etc., etc. So it has been a thing that's worried us for a number of years. Now, on this wonderful central map, if we can go back to the core, you all right there, Anne? You get, that's it. If you just drop back a bit, drop back to you. That's it. You stay with this, viewer. You're going on a planetary exploration into the universe here. Come back a bit further. What we've got down here is the new sort of accountability of the system to you, me, and everybody else. This was to give local education and training boards, which should ensure that the standards that are delivered are equitable across the piece. But when we get to the top here, you've got Local Health Watch, which is a service that's supposed to be delivered by your local councils, Health Watch England, and then on the outer ring you've got the Care Quality Commission, which does all, you know, tells us that we've got a failing hospital or a failing care home, because their responsibilities have expanded quite widely across the piece, and they are all responsible to the Department of Health. So if we sort of look at this wonderful concentric circle as a piece, if we could perhaps come back out again. Whoops, hold it there. Yeah, it's not that clear, is it really? We could do with a high definition camera, a very big screen, and the meaning of life. Hold it there. Okay, what you've got on the outer ring is Parliament, Department of Health, oodles of other government departments, but the key fella is this guy down here, the Secretary of State for Health. And if you look at him, he seems to have repositioned himself so that he's not directly in line with the flat, which is the regulatory ring, which is the next one, and safeguarding, that's you and me. Then you've got national organisations, which are things like Public Health England, the NHS Commissioning Board, the NHS legislation, NHS Blood, Health and Social Care Information Centre, a whole raft of bodies of national organisations. But the things that involve us really are the local organisations. And as you can now see, that in local government, and I don't know if we can come down into that, we've got a whole new series of responsibilities that local government will now be responsible for, in that a number of the public health responsibilities that previously were discharged by the Primary Care Trust will now be their responsibilities. So if you like, where we've had sort of smoking issues, we've had healthy eating issues, we've had under-exercising, that was the PCT that was endeavouring to encourage you, me and everybody else to live a healthier lifestyle, A, so that we have a better life, but B, so that our health costs aren't so high. So therefore, that is now devolved back to local government. On the basis that a lot of this is actually education. You need to start with kids at school. They need to be healthy. They need to appreciate healthy food, exercise, etc., etc. If we move along this inner part of the galaxy, we then come to the clinical commissioning group. And for us now, that's GPs. And the GP we have in our town, who is deputy chair of the committee, is Billy McGee up in Walton. And I'm sure that the rest of the GPs in the town will be communicating with him as to what their specific problems and needs are. We then move around the ring, if we can, and we get to Local Health Watch, and it's right in here, sitting below Health Watch England, and that used to be an organisation called Links. Some of you may have joined it, some of you may have known of its existence, but fundamentally they should monitor what service provision is happening where we live, and they will be spread across the same geographical area that used to be East Suffolk for us. The real problem, as I perceive it, is the fact that they don't have any statutory powers. The local health organisation before 2001-2, when the last major reorganisation took place, they were the folks who did have power, and they could refer things back to the Secretary of State. For instance, they were able to refer the whole first attempt at closure of the Bartlett back to Frank Dobson, who intervened and said that wasn't really in the interest of the community and actually stopped that first closure. So that's what they should be able to do. The trouble is, a number of us feel that they are very well meaning, but what statutory powers do they have? So hopefully we can get an update on that. If we then move around the outer ring of the inner ring of the central ring of the, it looks to me as if the folks in the middle are going to get crushed by these rings at some point. You then come to the NIHR Clinical Research Networks. Now, these are, if you like, work that is being done as a study to improve health. I note that they seem to work very well with our district hospitals, GPs. If there's a particular thing that needs researching, that's the boys that locally will be doing it. And then if we come on down here, we get back to the local education and training boards. So they're the folk who are going to be responsible for ensuring that the folks that treat you, me, the dog and the kitten are fully trained, and that's where they are. So if we come now into the inner core of, I'm trying to think what this best looks like. It could be slicing a tree, couldn't it? Rings on a tree, or it could be the universe. It could be whatever it is, but it seems to become the current thing. I don't know, can you get it into there, Anne? Sure, you got that. Should it go to where the health and well-being boards are? That's not bad. So in here you've got this wonderful representation of the whole community, a guy in a wheelchair. I think that could be mum, it could be, I'm not sure. So those are bodies, mum with a baby. And what you've got here on this inner ring is your home, personal helpers, care homes, community groups, the online phone service, which now is this 111 service that everybody is getting somewhat agitated about, the GP surgeries, the ambulances, the hospitals, the health centres, the pharmacy, the dentists, the opticians. So those are the sort of types of services that the people in the community need, that all of these outer networks are supposed to do the best they can to deliver in the budgets that they have. And a big question we have, of course, is our budget is very small in view of the increasing demand that is thought to be going to be made on it by an aging community with inadequate care facilities existing in the community, such as we have lost capacity, certainly on the coast. An awful lot of our services that we had have been relocated back on a sort of a baseline running along the A12, insofar as if we look at what the out-of-hours service provider, Harmony, based in Watford, recently were allowed to do. They were allowed to close, I believe, a base, but relocate the rest, and they now do not use either the community hospital in Felixstowe or Aldborough, which then makes them less secure on the basis of their delivering less services. So each time you take a service away from our district hospital or our community hospitals, it makes them in the long term more vulnerable to closure. I would like to, I don't know whether we can really run with the money too much, because this was, as of 2010-11, the NHS Suffolk then spent £915 million on the health of the communities here in NHS Suffolk, which, as I said earlier, was everywhere in Suffolk excluding Lowestoft. Lowestoft saw the writing on the wall chairing that appalling changing for the better consultation, and they opted to join with Yarmouth because they thought they could deliver a better health service for their own community if they delivered it across the River Yar, with Yarmouth and Lowestoft helping each other. And I understand they've kept their care homes, they've kept a lot more of community facility. I would like to end up on this wonderful engagement, and if we can get here, because a lot of people couldn't get there at all. Now, if you look at this, this was your new health provider having a public meeting on the 9th of April down in our town hall. And the time chosen was, doesn't actually say it, does it? It was 7 o'clock. So there's no buses. It's not the easiest place to get to. And the attending councillor, there was only one, when he listened to some of the exchange between the two presenters and the 13 people that were there, his view was, why here? Why this time? Why is this sort of presentation as poor as it is? Because I think he was expecting an exhibition telling us what we had, what they were going to change it to, and sadly, that didn't really happen. What we wanted to know, out of the existing staff, how many would they be getting rid of, and how would they then maintain the service delivery that had previously been promised when they were awarded the contract of £140 million for 3 years, running community health and also our community hospitals that we have in the NHS Suffolk area. And I had to wait until the 10th of April to find out the answer to a number of questions, and we can come to that later. But again, look, we've got, haven't we, yet another, look, you can see. We're all now going into inward implosions or cutting through a tree, but this is something that, if we can, I think it would be very good when we go on to the website that we actually take all of these and put them in as what the presentation was that was given by these folks on the 9th of April. So that shouldn't really be a problem, should it, Anne, to do that? So if we do that, let's go on to what happened on the 10th of April. And this was in the Financial Times. And en route to somewhere else, I happened to drop into the library and have a quick scan through the Financial Times for the 10th of April. And would you believe it said, healthcare approval is tough task for the company that's been awarded our service, an outfit called Serco, S-E-R-C-O. And I don't know whether Anne can get in here, but it's perhaps something, again, we could put on the website. But if you could get into there, Anne, can you see that? Yeah? Now, this is the Financial Times. The author of the article is a Jill Plimmer, and what she has said is that Serco initially thought it could run the contract with 137 fewer employees. Now, bear in mind they only have 1,003 anyway. That's a reduction in staffing of, what, 13%. Now, what we also asked for, and have never been told, what profit does this company expect to make out of running this contract? This article, if you could get it, tells you that they are looking to make 6%. Now, 6% profit on 140, somewhere around 8 million plus, I suppose. So that's 8 million plus that won't be going in to delivering healthcare to you, me, your family, your friends, your kids, your grandmother. That if they can actually deliver the services, what they seem to be relying on, and sadly I've heard it so many times, particularly in the NHS, that a computerization of service delivery will enhance the service, and that they are claiming, and this would be wonderful if it were ever to be delivered, they are claiming a 50% increase of clinical contact time by the district nurses by using a tablet. Now, when they said that to me, I thought it was the type of tablet that you take and you then become super efficient and you run around like a demented. You know, a lot of the troops used it in Vietnam to keep going. Here, I think it's illegal, but apparently it's not. There's a tablet which is actually a computer device, a small computer, which will do all their admin. So what they seem to be saying is if the admin is done by somebody else, then this will free up a significant amount of time for the district nurses. Whether that ends up being delivered or not, we're going to have to wait and see, aren't we? But the reports currently on the ground don't seem to be supporting it, but they are going to invest in this. Where this money comes out from, I'm not sure. Whether they may defer their profit for the first year, because it is important to them for their worldwide bid for supremacy in community health that they have a system working somewhere, and their first crack of the cherry, I'm sorry to tell you folks, is here in Suffolk, because they were awarded the contract, one of the last acts of the dying Primary Care Trust, NHS Suffolk, totally unlamented, now it's gone, on the basis of what it did or didn't do. So I would recommend that if you can, you access this Financial Times article. I don't know what the arrangements are for showing articles from serious papers on a community channel. Perhaps we could email the Financial Times, and in that it's pertinent very much to our community, and ask them if we could reproduce this on the channel so you can have a look. Well, I've taken more than enough of your time, but what I am hoping is that we will get a GP in over the next week or 10 days or so we can do a reprise of where we are now. And I suppose what you're really all interested in is, will we actually get the same care, better care, different care? What do you do? Where do you go? And let's hope that it's better than it's been.